growing weary of running from room to room, practicing one-tooth insurance-driven dentistry? Then stay tuned for the latest episode of The Lionhearted, where Dr. Stephen Rasner will hand you the blueprint for what many call the gold standard of general practice dentistry.
Hi everyone, Dr. Steve Rasner here. Welcome back to The Lionhearted. This is pretty cool today because it's a Friday, which I'm off. And I came back in my office. There's nobody here. And this is where my podcast started some 6, 7, 8 months ago. I thought I would always be doing them from my office, but as it turned out, as you can tell, those of you that can see me, I do a lot of them from my home. But I'm back in my office. There's nobody here. And I feel like I can concentrate and hopefully contribute this week to your success. And remember, the Lionhearted, the reason I called it the Lionhearted is because I think it takes a lion mentality today in dentistry to really super succeed and not just give in to corporate dentistry or sell out or, live a life of one-tooth myopic dentistry where your treatment and your practice actually is toxified by the changes in insurance over the last 12 years. So all of my talk evolves from a place that I don't do that. I'm an independent fee-for-service dentist in southern New Jersey, which is, those of you that have been listening to me now for a while know that it's not the easiest area in the United States, and I know there's many areas just like this, to sustain this type of business. So everything I come up with that I talk to you about is geared towards, wow, I didn't know I could do that, or maybe I should try that. And there's another thing why I'm on that is the 120-day rule. I don't have many things I've come up with that are totally mine, but this one is. And that's what I call the 120-day rule. So if you hear something I've said that you say, I'm not sure if I want to try that or do that, try it for 4 months. And if it doesn't work, just disband it. If you're sure by trying what I'm going to suggest to you won't implode your practice, and I assure you, I'm not here telling you to open up a second business in a second or third dental practice that'll cost you, $180,000. That's not what this is. These are all ideas that you can implement without any significant cost. So the only challenge you have and the only risk you have is the fear that maybe you'll get rejected or it won't work. So that being said, I always like to start with my email, and I would hope that more of you do reach out to me so I know you're listening. And that email is my name, Dr. Rasner at AOL. DRRASNER at AOL. And again, I give courses in my office, and I give courses around the United States and sometimes abroad. And you can find those courses on rasnerinstitute.com. And the only course I have left in my office this year, the 3 courses I have left are my atraumatic extraction site development course and implant course, where it's live hands-on, that you can come as long as you have an active license and malpractice in your state and I believe Canada. Then you can come to my office for 2 days where I provide the patients and we do the procedures you have asked me through an application to do, as long as I feel your background warrants that. And I'm only talking about implants in terms of me checking out what you've done in the past or not. We can do atraumatic extractions and bone grafting and all these things. It's pretty cool. It really is cool. We even anesthetize the patients so you don't have to waste time doing that. Because I want all your time spent on surgical procedures, not waiting 15 minutes for the patient to get numb enough. All the patients are orally sedated. So you're practicing, and the group is limited to a maximum of 10 dentists. Usually it's 8. So there's a lot of one-on-one, a lot of time for you to not get, overwhelmed. We have all the time. We try to give at least 2 hours for each procedure. So it's a pretty great experience if that's what your thing is. And I also have brought in a couple people this year to speak at my institute, which is my office. John Suzuki, the legend John Suzuki, is going to be here in a month talking about connective tissue and free gingival grafts, either on teeth or implants, and that's a hands-on course. And then the last one is a really cool course I'm giving in July, late July, with the oral surgeon Frank Zastro from Germany, where he'll teach you how to amazingly grow bone horizontally or vertically with bone membranes, that you harvest bone membranes, and he teaches you these amazing results. You can check Frank out on Real Bone Builders on Facebook. So had to plug those things because they're important to me. But let's get back to you and what I can bring. Last podcast, I told you it would be 2 parts. And I was doing something I hadn't visited in a while. I was talking about case presentations. And I was talking about how taking that moment, which, if you think about it, it's pretty unique to take the moment that you're really recommending to somebody you recently have met, and you've recommended that they're going to go a certain course with their oral health. And in doing that, it's going to, it requires an investment out of pocket, because it's quite impossible to not go that route if you're doing comprehensive examinations. And again, if you follow my blueprint, there's a whole sequence of events that begin with the very first phone call. And if you're tuning in for whatever reason for the first time, go back in my podcast, because this is really quite literally the second time I've visited this concept, because to me, it's so essential to your success. Whether people say yes or no to you has everything to do with what you're going to be doing next month. And it's a big deal. It's a big deal because here's why it's a big deal. Most of the profession doesn't have a protocol of comprehensive examinations when they meet a new patient. Let's be honest about it. Most of the profession is insurance driven, and I get it. And there are patients out there, I guess, who have very minimal needs that occasionally you probably could get by on insurance-driven practice. But if we're really being honest with each other, you can't run a successful practice, meaning having patients have successful high-end oral health that's determined by an office somewhere in Hoboken, New Jersey, that happens to be the headquarters for Insurance X company. I mean, let's get real. Where does that fit into the parameters of what a patient needs to have an oral functional dentition? So again, if you followed me, go back. If you're new to this, go back and look. But the last time we spoke, I talked about taking this opportunity, which sounds a little ironic, and using it as a moment to gain trust in the patient. Because why I can say that to you is because my approach is to just be patently clear to this patient why you are taking this approach, not using special sales techniques so they'll say yes. That's not what I'm asking you to do. I'm asking you to lay it out there a different way than you've been doing. Taking the chance on these patients that may recognize this is a much better way. And how do I know that? I mean, how do I know after 39 years that this approach is? Because most of my older patients have the same teeth that they came to me with 4 decades ago, unless they were just on the fence of a terminal dentition due to perio, and we both knew they were hanging on for whatever reasons, and that can happen. And now that since that time, they've gone into dentures or implant retained prostheses. Other than that, if they sought a certain therapy that I recommended, be it periodontal therapy or orthodontics or endo or tooth replacement, in an effort to maintain as many teeth as they can from the time I met them to the end of their careers, then I can tell you that I have a pretty high success rate with the approach that I'm trying to share with you. So again, and I really think it's necessary to really lay this out clearly, I'm not asking you to do anything that's not authentic. I'm asking you to take another look at this, to not walk into a patient that came to you. Hear me out now. They came to you because they had pain on number 30 on the lower right molar, and your initial approach is to do root canal on that tooth and really not examine the entire dentition. And there are many people that believe that is the best way, to go after what they came to you for, create a bond of acceptance and trust that way, and later down the road, their other work, they may come to you for that. And I think that creates a practice of emergent care, that your whole practice will be centered around people that have a broken tooth, a filling that fell out, the pain I just described, a loose tooth that they want removed. And I say that you just don't have enough time in this career to take that approach. And if you really think about it, the reason I say that to you is because most of us don't think about this, but we're a little bit like plastic surgeons in the sense that you don't have to treat your emerging dental problems to stay out of trouble all the time. Because we all know that the profession you and I chose is kind of an oddball profession in the sense that things can be dramatically wrong and that they don't have to hurt. So it's confusing to this patient, by the way, who's gone to good old Dr. Joe, who I'll get back to in a minute. And good old Dr. Joe for their whole career has just said, you look fine. Well, watch this. You look good. And as they overlooked pathology that doesn't hurt this patient. And now this patient somehow ends up in your office. And you just do an honest examination that this new patient is suspicious that you may have ulterior motives. When you don't. You're trying to do the things you learned at Pankey or Dawson or whatever group you subscribe to. So everything I've told you and everything I do is a process that starts at the first phone call, like I've said. And I really do believe everything counts to get this patient to buy in. I really do believe that how you look when you walk in that room. I know some of you think I'm kidding, but I think it's worth stopping and washing your face and making sure there's nothing on your teeth, because I'm very aware of the fact that people make decisions about us in seconds, really before we even speak. So I really do believe that not only do you have to look good and take that time, but then you have to also have a system in place before they even get to you, that you have a great patient advocate on that telephone that doesn't sound salesy, that sounds compassionate and caring and can somehow give off the vibe that it is worth going out of network and it's worth giving this patient, this practice that they're calling, a try. Because let's not kid each other. I'm kind of tired of holding it in here. Most patients that I have met in my career would rather go to good old Dr. Joe. Even patients of socioeconomic means, that have education, that have a financial background that doesn't limit them. Have you ever noticed, I have, that poor dental IQ is not consistent. It's not consistent with patients with low socioeconomic means. Um, it can, if it, I think low dental IQs transgress all economic standards. A lot of people, look at some of the pop culture stars in our society, to have just awful smiles. And you wonder to yourself, how did that happen? And that's because that's the nature of what we do. That's the nature of what we chose. So here's my approach. My approach is to give all patients a comprehensive exam and let it fall out where it falls out. If they say no, then you'll see in my last podcast, there are lines in the sand that you have to draw. That where is the bottom line in your practice? So for example, let's say that somebody came into you and they're bruxers and they want you to do 7 through 10 or 6 through 11 because they've worn considerably, but they won't let you open their vertical and they won't let you replace and balance their dentition that has many teeth missing. But you see perhaps dollar signs because they're hell-bent on spending whatever it takes to fix what they think the world can see, be that 7 through 10 or 6 through 11. Well, that damn sure better be the line in the sand if you're listening to me. I mean, who would pursue that? That is, and maybe some of you would. Now there are compromises I've done in my career. An upper right second molar all the way over to number 11 with full coverage, and I had to maintain balance on the first premolar to the second upper left second molar with composite buildups because another 5 crowns was not something they could afford. I did a case like that lasted every bit of 25, 30 years. And I don't know what happened to the patient after that. Yeah, over the years, sometimes we had to replace some of the composite that wore down or chipped. Yeah, there are compromises for sure. But you have to decide. I've had patients want me to restore a tooth in the smile zone, yet they would not treat periapical lesions that I showed them on their x-rays. And this patient I'm thinking of as I'm talking to you was a doctor. Think about that for a minute. Patient, look, I'm a very candid guy, as you know by now. So I can't help sometimes. I just fall into being candid. And think about a patient comes in on a very bad week for you, and he's willing to restore 2 teeth or 3 teeth, but he's not willing to treat class 2 or 3 periodontal disease. And he's not willing to deal with periapical pathology that you see. I mean, to me, that's a clear, easy line that I can just say no to. But, we work in a weird environment because we're by ourselves most of the time. And nobody can see, no one can see what your decision outcomes are until they're done, maybe years later, right? So it really creates an onus of a very high integrity, whether somebody's watching you or not, when you're making these decisions, right? So I hope this is resonating because I really feel connected right now to these thoughts as I'm trying to lay the path for you or the blueprint for you as to the road I would take when it comes to treatment planning. So again, I'm going to get more specific and go back just a little bit for review. But I did say to you, I would never walk into a patient and say, well, look, one thing I'm going to have to begin with here is a comprehensive exam. You simply can't utter those words. I'm trying to make this a verbal blue-collar approach, if you will. And I've never said that before, and I don't even know if it's the right description. So when I say to you, don't say comprehensive exam, right? I'm assuming right now that you are doing everything else I've told you in the past. Okay, you've had the right telephone call. They're greeted properly when they walk into your office. Even your reception room looks a certain way. You have a stud assistant taking the necessary x-rays. And then you walk in with ample time. And you've greeted them and you've done the obviously obligatory and appropriate social interactions. Hey, how'd you guys find me? And by the way, you've brought in a significant other to that first visit, or you've at least tried to do that. You've at least asked for that. If you're not doing at least, if you take nothing else from this particular podcast away than having someone who indicated need to you, and you did not have their significant other there or even approach that, then you will gain tremendously just that pearl as you watch this particular podcast or listen to it. But I say, and I know I said this last podcast, I walk in and say, look, I know you called me with a specific tooth. I mean, everybody does that. I get it. But I need you to know that I'm looking, as Michelle told you, and my new patient advocate coordinator has told them that I'm examining their whole mouth. And I am going to take whatever necessary x-rays, models, or diagnostic needs I have, that they were quoted on the fee on that. And if they won't let me even do that, then they're not coming into my office. And maybe somebody could make an argument for a different approach. That's another line in the sand that I draw. If they're not going to let me do that, then there's no sense in pursuing this particular journey together with the patient I called my office. So I tell them that, I'm going to look at the health of 5 things. The health of their gums. And I say gums. And I explain why. It's on my last podcast. I know you know why, but I want you to hear what I tell the patient. I tell them I'm going to look at all their teeth. Their missing teeth, that's number 3. The health of their joints and muscles. And 5, their aesthetics. That's it. They're the 5 things I tell them I'm going to look at. And I have to tell you that I can't remember having anybody tell me that, well, I don't want all that. Because they were prepped that I'm going to do that. And I know I'm kind of beating this to death. I think I have to beat it to death. And then I told you in the last podcast that I really think the single moment of truth that's happening between you and this new patient occurs when you go and you look up at that screen in front of you at the FMX that was taken. I said to you that I believe when you look at most adults on those x-rays, you're going to see a missing tooth, a root canal, a crown, which is a good thing. Because as soon as you see that, it empowers me to do this comprehensive exam and easily explain the virtues of it to this patient. And just check my last podcast for how I handle that. You're in a nutshell, you're pointing out that, the root canal they had done, the missing tooth that's missing, or the crown they had may have not been any of those 3 things. Had we had an approach to their mouth like this years ago, because we would have gotten to the problems years ago. And then I say this. I say, the mouth is unlike any other part of your body. Like, I love saying this. I said, if you woke up today with the slightest fever, I mean a 1/2 degree above normal, would you need anybody to tell you that you didn't feel well? I said, here's the problem in the mouth. If the abscess you have or the diseases that can occur were on your arm, then indeed you would see them and you would be motivated to treat them. But that's not the way it is. You can have substantial things going on in our mouths and they don't have to hurt. And so it becomes the onus of helping you is on me. It's on me to find things. If you choose not to treat something, that's your decision. But the onus on me is to lay it out there for you. And by the way, guys, a lot of times I say right then and there, and I'm not here, Mrs. Patient, Mr. Patient, I'm not here today talking about changing ugly, so I'll say it just like this, unattractive or ugly silver fillings to white fillings because I want to make them prettier. I am not speaking of that. To me, you either have decay or you don't have decay. And I am in this long enough that if a filling's unattractive, and that's all it is, I may note that to you, or note that this is an old restoration, and maybe someday we should, replace it. But I'm not the guy that's going to change your fillings to fresher, newer white fillings just because they're not perfect. And I'm telling you, that's what I mean by a blue-collared approach. I mean, that just rolls off my tongue when I'm speaking. It's easy for me to say that because I don't want them to think that's what I'm thinking. And I'm telling you that because, in the wave of dentistry in the last 8 years or 10 years, I never remember more patients, and I find this almost amusing, coming to me for a second opinion. Because, look, I've been in my same area for 39 years, and, you are who you are, and certainly patients don't flock to me, and I say this because I'm the Kmart or Walmart of dentistry, because I'm a discounted dentist, because I'm not. So when a patient comes to me, wants a second opinion, by the way, I'll tell you how I handle that in a second, I love that. I love that they respect my opinion on this. And the reason that's happening, I don't know why it's happening. I just know that more than ever, it seems that a patient that's gone to a dentist for many, many years, and that dentist died, sold, changed, retired, very often the next dentist, and even if they mean well, is lacking somewhere to create not the trust I'm talking about to you, but a lack of trust. And the end result of that is they don't believe that they have 8 cavities that they may have or not have. And what I say to that patient is this. I said, well, I'm going to, I go through everything else I just told you that I go through. And then I say, I want to tell you something before I even look in your mouth. I always say, and I'm saying this to the patient, I always say, it is what it is. When I look in your mouth, I may not think you have 8 cavities or 8 fillings to do. I might think you have 12. Or I may think you have 8, or I may think you have less. It is what it is. And that's what you're going to get from me, the absolute truth. I can't tell you how many times, and I'm sure it's happened to some of you, where a patient's come into me and they had a quote for work, and my quote is substantially higher, maybe 50% higher, because you have to tell the truth of what you think. You can't change your treatment plan to get the patient to like you. And if you say it, and you notice something, my tone of voice is pretty much what it is when I'm talking to these patients. And I know that you know that it's honest and truthful, because it is. And so when I'm talking like this, I just got to tell you, I don't know how else you can approach this. To me, it is so patently clear that this is the way we should be approaching our patients. And in the long run of things, I don't get it. I mean, I just came off a miserable week. I've said this 20 times probably in these podcasts. I say you need 3 things to have a great week. You need new patients often, new patients that need something. They don't always need something. New patients that value and understand the need that you discovered, the treatment that they need. And then 4, the financial ability to pay for that need, to pay for those needs. And this week, I had just a couple new patients, and I had people that believed me, for sure. But I didn't have anybody that had the finances. And we're not talking, I've had treatment plans significantly more than the treatment plans that were given this week. They had no means to pay. In fact, I don't even know what they were thinking. They had no means to pay for any out-of-pocket costs, quite honestly. And, I guess that's where it ends. So you need those things in a given week. So I want to move on to something else at this point. I want to move on. And this is the reason I'm going to talk about this and end the podcast with this particular sequence is because it's become such a big, hot topic these days. And that is the patient with the terminal dentition. Everybody listening knows, whatever area of the country or the world you're in, there is all on 4 and all on this. has become significant marketing in the United States and abroad. And I'm not personally convinced, it doesn't matter what I think, whether that's the exact approach you need to go to. But the point is I've never seen in my career more patients conflicted with decision of a terminal decision, a terminal dentition. In other words, they are confronted that perhaps the best way to go, not perhaps, that the best way they should go is to eliminate their teeth at this point and go to what they're recommending. So I want to tell you specifically how I handle that patient, because I think the way I do it is a very clear way, and I didn't used to do this. So I want you to know this as I wrap this up. So first of all, I am talking generally in my world about one of two patients. One, they both have significant missing teeth already. They have a negatively impacted dentition, occlusion, as a result of all the missing teeth. And then the patients fall into one of two categories, or both. Either they're advanced perio, missing over 50% of their bone or more, or they're patients, and those patients probably are wearing some type of partial dentures, or they are patients that don't have a lot of bone loss, but they have significant destruction of their teeth due to their oral chemistry, whatever that chemistry has been. And they may have had significant work done in their careers, including root canals and crowns, and they have recurrent decay everywhere. So I think that's a clear picture for most of us easily to understand. So to me, those two patients can easily be grouped into perhaps this is the end of their days with natural teeth. But both of these patients still have teeth. Okay, so I keep a box. I think 3D communication is, and I mean models, is incredibly essential for this patient, as opposed to videos, fancy videos that you may have purchased that will show the evolution of what they can expect when they extract all their teeth, or photographs. I actually have models, very well manicured models of a denture. And I also have models of patients with, you can buy these models, or they could be cases that you've duped the models on your own over your career. Whatever way you want to go, I want you, this is one of those critical moments that I bring up from time to time. I think you need to think about your protocol. What are you doing with this patient when you start talking about that? Because let's agree to this. Most patients that I've ever said, I know that one of the choices that you may have thought about would be dentures. And I would tell you that 98% of those patients nod their head when I say that. I can't even remember a case where that was a shock to this patient. And so I want to talk to you about what it's like to have a denture. And it's important to me that you understand visually what a denture is and where this is going. Okay, and then I literally turn to, remember, they're sitting there usually in the operatory chair, and next to them is their significant other. And I love it like that. And I literally turn to the models, and if you want photographs of this, please just write to me, and I'll have Beth email them to you. These are not to use. I want you to know what I am using so you can duplicate this in your office. And I'll take an upper denture, for example, and I'll put it in their hand. The denture's never been in anybody's mouth, obviously. It's clean, and the models are obviously clean. And I will point out what the difference is. I'll say this. I'll say, I want you to understand, as beat up as your teeth are right now, and sometimes I say it just like that. I'll say, as beat up as your teeth are, when you go to eat, you are eating right now maybe as well or even better as you would with a denture. And here's why. And I point out the limits of a full upper denture. I haven't even got into the lower denture yet. but just stay with me. We're going to run a little late on this podcast. And I'll show them the roof of the mouth will be covered. And then I will show them a picture of ice cream and a potato chip. And I'll say this. I'll say, when you eat ice cream or a potato chip, just as an example, if I say that to you right now, in your mind, you are conjuring up that taste, because part of that taste is coming in your mind from picturing how that feels texture-wise on the roof of your mouth, because it's true. When you eat a potato chip, it's not just it's crisp and salty. You can feel that on the roof of your mouth. And they think you're amazing because you're pointing out something very obvious to them that they know is true. And I said the same is true with ice cream. And they're just two examples. It's really true with almost all food. Pizza, Italian food, whatever I'm talking about, part of the sensation of taste comes from the feeling of texture on the roof of your mouth. And you're going to lose that. You're going to lose that because of this denture that I'm showing you right now is going to cover this part. And if that is okay with you, it's okay with me. I just want you to know the limitations of where you're going from right now. And you have to make a move. It is not healthy for you to stay in the condition you're in. And I don't want to be the guy on your watch that didn't take the time to communicate this to you. That's why I'm doing this. And then I'll show them a mounted model on an articulator of an upper and a lower. And I'll simply say this. I'll say, as bad as the maxillary, the upper denture is, almost everyone does better with that than they do the lower denture, and I want to explain why. And I show them that the lower jaw is on a hinge, unlike the upper, and that the fact in the center of their lower jaw is their tongue. It's not attached to the roof of their mouth. So when they swallow, and I talk just like this, I said, so when you swallow, when you speak, there's muscles attached to the tongue that want to drive the lower denture out and up. And it's an incredibly epic challenge. And I'll say this, and I'll say, I know you might know somebody that tells you they eat corn on the cob and they don't use any lower adhesive. And I am here to tell you, not because I want to scare you, because I want to inform you that those patients are unbelievably rare. That most patients live a life married to glue that they have to put in these dentures and are very limited by what they can eat and are intimidated and handicapped to go out in public and eat in a setting where other people are because they could have an embarrassing moment. And that's how I speak when it comes to a terminal dentition. Obviously, I haven't got into the implants, and we'll do another podcast on that because it's such a raging part today of your case presentations. Anyway, I really hope this has helped some of you. It felt good today. Wishing you all the success in the world on the Lionhearted. See you soon.